Hello, welcome to video number 3 for the Florida MPJE Bootcamp. Today we're going to be covering Chapter 2 again, but the second half of Chapter 2. So we're still doing Florida and Federal Controlled Substances Act. We left off on page 62. Before we get started, I do have to mention again that I am not affiliated with NABP. I have no specific knowledge of any questions on the MPJE. And this course is not endorsed by or affiliated with NABP. And the final reminder, these slides, videos, and audio programs and the book are all copyrighted material and may not be reproduced, recorded, or stored without permission of Florida Pharmacy Regulatory Advisors. Okay, so we left off in the middle of Chapter 2, and we're on page 62. And now we're getting to the actual dispensing of controlled substance prescriptions. So a lot of what we did in the last video had to do with record keeping and forms and things like that. So this is more stuff that you have to actually do in practice. And you're going to see probably a lot more of those situational types of questions that come up on the MPJE covering this particular section. So the first thing we have on page 62 is the pharmacist's corresponding responsibility. And this is an area that's become a huge issue within pharmacy with the opioid crisis that we've had, because it has to do with the fact that DEA requires for a controlled substance prescription to be valid, that it has to be written for a legitimate medical purpose and in the usual course of professional practice. And the rule that addresses that says that the prescriber bears the primary responsibility for making sure that the prescription is valid based on those terms. But there's a corresponding responsibility that falls upon the dispensing pharmacist. And those are important words because what that means is the pharmacist can't simply accept a prescription for a controlled substance from a prescriber simply based on the fact that they have a license and they have a DEA registration. If there's something about that prescription that would lead a reasonable pharmacist to question it, question the fact that it was not issued for a legitimate medical purpose, or question the fact that it was not issued in the usual course of professional practice, then it's not a valid prescription and you can't fill it. And what are those things that would cause you to question that? Well, the term that's been used a lot that you'll see is red flags, and I think red flags actually shows up in the MPJE competency statements now. There's lists of red flags that are out there. DEA does not have those specific list of red flags in their regulations anywhere. Florida used to actually list some of the red flags, but they actually, you'll see in a minute, Florida took the specific red flags out of the regulation. And I think that's a good thing because you got to use your professional judgment here. I mean, the pharmacist is really the last line of defense in trying to prevent the inappropriate use of controlled substances. I could spend probably an hour or two or more talking about this issue. It's an issue that I've dealt with in my professional career for the past 10 years, practically. But I think you do need to be familiar with what the red flags are. You can Google list of them. There's videos out there that talk about them. Obviously, it's professional judgment, but so I would think on an MPJE exam, it's going to have to be fairly obvious, right? I'll just mention some of them that the DEA expects you to be looking for, right? Is things like distance, right? Is the patient coming from a long distance to go see a physician somewhere else, or a long distance from the pharmacy? But these are not absolutes, right? Because sometimes that's legitimate. I live in Houston, Texas. We've got MD Anderson is the top cancer hospital in the country. And patients come to MD Anderson Cancer Center from all over the country. And some of them get prescriptions filled here. So are we going to deny those prescriptions because they're a long way from home? People come from all over the world actually to come there. So you got to use some common sense here. But if you got a situation where, you know, you got multiple people coming into your pharmacy, all from out of state and they're all going to see the same physician and you don't know who that physician is and these are all for controlled substance prescriptions, that's a red flag. If all those prescriptions are for the same drug, all for the same dosage and often the highest dosage of that drug, you know, if they're all coming in and you're seeing prescriptions and everybody's getting the same thing, right? And the famous combination is oxycodone and um, alprazolam and Soma, right? Or sometimes the oxycodone is replaced with hydrocodone. You know, just that combination in itself is a red flag. Are all the alprazolams 2 milligrams? There's no individualization of the dosage for patients. Um, you know, is the prescriber um, uh, a board certified pain management practitioner, or do you have a retired um, pediatrician, you know, writing for adults now, working in a clinic? That would be a big red flag. Do you, or an OBGYN doctor writing for males, right? You got to question all these things, right? But so you got to use some common sense. And I will tell you, because there's been a lot of enforcement in this area by the DEA, taking enforcement actions against the physicians who are writing these prescriptions and also against the pharmacies who are filling some of these prescriptions. You know, the pendulum kind of swung too far the other way, and a lot of pharmacists have become hesitant and scared to fill controlled substance prescriptions that are actually legitimate. And because of that, there have been complaints, and this was particularly an issue in Florida, that patients can't get access to controlled substance prescriptions, legitimate patients. And it got to the point where this became a big issue in Florida. And so Florida actually developed a committee to address this issue that the Board of Pharmacy put together to try to ensure that legitimate patients can get their controlled substance prescriptions filled, while at the same time trying to prevent the diversion or illegitimate prescriptions from being filled. So the rule that they developed, actually the rule is already out there, but they just modified the rule. They call it the standards of practice for filling controlled substance prescriptions, and you see it on page 62 in your book. And the rule number is 64B 1627.831. If you want to, you know, read the whole thing. And what it says is that pharmacists must validate controlled substance prescriptions. And if you have some concerns about the validity of the prescription that you can't resolve, if you can't resolve those concerns, you shall and you must refuse to dispense the prescriptions. We're trying to prevent those illegitimate ones from getting filled. But they also put in some minimum standards. But before you do that, we don't want to deny people from getting legitimate prescriptions. And letter B, they set up some things that you should do before you refuse to fill it, you know, just based on those concerns. You have to at least attempt to try to do these things. And this was, some of these concerns came from physicians who were on this committee saying that my patients can't get their prescriptions filled. And actually patients came and testified in front of that committee as well. And they said, look, you at least have to initiate some type of communication with the patient to get any information, you know, get more information from the patient. And also, on top of page 63, talk to the prescriber to get any relevant information. And then after, the rule goes on to say that in lieu of doing those two things, in lieu of means instead of, right? Instead of doing those things, but not both of them. You at least got to talk to the patient or the physician. You can just access the PDMP. Now I put a note there. They wrote this rule, but when checking the PDMP was not mandatory, and we'll cover that a little bit later. But there is mandatory checking of the PDMP, the Prescription Drug Monitoring Program now. So the rule doesn't really make a lot of sense the way it's written. They probably need to modify that because, well, at least for certain, there are some exceptions to when you don't have to check the PDMP. So I guess it still applies there. But that's the way that was set up. And they also said that if you know of a physician or have any reason to believe that a prescriber is involved in issuing prescriptions that are not valid, you must report that to the Florida Department of Health. Realize the Florida Department of Health is the agency that all of the health professions fall under. So the Board of Pharmacy, the Board of Medicine, all fall under the Florida Department of Health. It's kind of an umbrella agency for a lot of the healthcare professions. So they will be able to investigate that and investigate that particular practitioner, prescriber. So that is a mandatory reporting requirement you do have. They also put in mandatory requirements for continuing education. You can see on page 63. And it's a 2-hour continuing education, and it has certain elements that have to be part of that continuing education. So I'm still licensed in Florida, so when I do my renewals, I always got to make sure that I have at least 2 hours of this controlled substance continuing education as part of my renewal requirements. If you turn over to page 64, there's also a requirement that your pharmacy must be able to print out a hard copy of what they call a summary record within 72 hours of requirement of a request from law enforcement. So if the DEA or some other law enforcement agency wants to see a record of which controlled substances you dispense, you need to be able to produce that going back 60 days within 72 hours. I put a note in there. I said it's kind of a curious requirement because law enforcement can actually pull that information out of the PDMP. They don't have direct access to the PDMP because of privacy concerns. But when they're doing an investigation, they actually can make a request directly to the PDMP, the people who run the PDMP, and they can actually get that information directly. So I don't know how often you would actually get such a request in a pharmacy, but for MPJE purposes, if you get a request from law enforcement, make sure you can print out the last 60 days of controlled substance prescriptions within 72 hours. I also put a note in there, there's a separate rule that says you have to produce records within 48 hours of any prescription you fill upon request from the Florida Department of Health. So the Florida Department of Health is not a law enforcement agency, they're a regulatory agency. So just be careful about how they ask a question about producing prescription records. If it's law enforcement and it's related to controlled substances, you got 72 hours to do it. If it's just the Florida Department of Health, which would be your Board of Pharmacy inspectors, you need to be able to produce records within 48 hours, and that's for all prescriptions, not just controlled substances. There's also in the statute, on the bottom of page 64, a duty to report to law enforcement, or to the sheriff of the county where your pharmacy is located in, any fraudulent prescription or any attempt to pass a fraudulent prescription has to be reported to the local county sheriff within 24 hours. And if you don't do that, you're actually breaking the law. So again, another mandatory reporting requirement that Florida has that you need to know and make sure you comply with. So I want to talk a little bit about prescriptive authority on page 65. So DEA, we're still talking about controlled substances here. So we're going to talk about who can prescribe controlled substances. DEA does not determine who can prescribe controlled substances. I think I might have mentioned that in the last video. The state decides that, and if the state says a certain type of practitioner can prescribe controlled substances, then DEA will issue them a DEA registration. So it's important to know who can prescribe and what limitations they have in their prescriptive authority, both for non-controlled substances and controlled substances. Obviously here in this chapter, we're focusing on controlled substances. So Florida recognizes and gives prescriptive authority for controlled substances to doctors, dentists, and podiatrists. And doctors being medical doctors who are licensed under one chapter, and then osteopathic physicians licensed under another chapter, and then dentists, and as I mentioned, podiatrists. Optometrists, certified optometrists can prescribe under their own license, so it's not a dependent situation like we have with the physician assistants, but they have a limited formulary. And as far as controlled substances are concerned, the only controlled substances optometrists can prescribe are tramadol and acetaminophen with coding number 3. So very limited for optometrists. And then you get to those mid-level practitioners we talked to. Remember when we talked about registration, the ones that start with the letter M are the mid-level ones because they don't have independent authority to prescribe. They are technically working under the supervision of a physician, and that's why they get a mid-level practitioner registration. Well, in Florida, they can prescribe controlled substances, but you'll notice, and we'll start with the PAs first on page 65, they can only do a 7-day supply of Schedule II controlled substances. They also can't prescribe, physician assistants cannot prescribe in a pain management clinic. They really cracked down on the pain management clinics because Florida had a big problem with a lot of these pain management clinics. So physician assistants, and you'll see nurse practitioners also, can't work in a pain management clinic. There's also a restriction on prescriptions for psychiatric mental health controlled substances. And those can span, I'm not sure if that term is defined anywhere, but certain psychiatric mental health drugs are going to be Schedule II, but I'm sure some could also be Schedule III or Schedule IV. I'm thinking anti-anxiety drugs, benzodiazepines would be Schedule IV. Things like Ritalin and so forth would be Schedule II. But they can't prescribe those if it's for children less than 18 years of age. So that's another restriction that these mid-level practitioners have. And there's some additional restrictions on the treatment of acute pain that we'll talk about that apply to everyone in Florida that we'll talk about in a moment. Then on the bottom of 65 and over to page 66, pretty much the same rules apply to advanced practice registered nurses. Advanced practice registered nurses, or APRNs, really encompasses different types of advanced nurses. The more common one you might hear term is a nurse practitioner, but APRN is a more broad term because it includes all advanced nurses, including nurse anesthetists, the psychiatric nurses, and so forth. So they have the same rules: no more than a 7-day supply of a Schedule II. They can't prescribe in a pain management clinic. Except for the psychiatric nurses, can't prescribe mental health controlled substances to children under the age of 18. So obviously we have a subclass of those nurses who are the psychiatric nurses. Couple things for them. Number one, they obviously can prescribe to children under the age of 18, but they can only they can prescribe psychiatric controlled substances to children under age 18. They're also not subject to that 7-day limit for Schedule II that other nurses are and the PAs are. And if you think, and I put a note there, that actually makes some sense. So if you have children that have ADHD and are taking Ritalin or something like that, which is a Schedule II drug, they may not want to limit them to a 7-day supply. So they can do that as psychiatric nurses, and you can dispense that to them, not to them, for them on a prescription from them, but not from a regular advanced practice registered nurse. All right, so then we get to out-of-state prescribers, and this one is a little bit interesting because if you look at the Florida Controlled Substance Act of a practitioner, it doesn't really talk about practitioners in other states. But if you look at the definition of prescription in the Florida Pharmacy Act, it does talk about prescription orders transmitted by practitioners in other states. And I think I put other states in the review guide. I think the actual language in the rule definition is other jurisdictions. And it says for those from other jurisdictions, which I consider to be out of state, you can accept a controlled substance prescription, but only if it's for a chronic or recurrent condition. Kind of interesting. So if it's an acute condition and it's coming from out of state, you technically could not fill a controlled substance prescription. Sometimes people ask me about, well, what about out of the country? That one's not clear, I think, because it's not addressed anywhere, but here's my interpretation. DEA, think about this, especially for controlled substances. DEA doesn't issue controlled substances to practitioners outside the country. So controlled substances are definitely out. I think they're definitely out for even non-controlled substances in Florida, because I think a state would have to actually affirmatively state that we accept prescriptions from out of the country. And most states do not accept prescriptions from out of the country. Texas, where I'm at, actually does recognize very limited situations, but only from two different countries, Canada and Mexico. Florida doesn't address that. So I would interpret the definition of prescription that says you recognize practitioners from other jurisdictions. Other jurisdictions to me means the 50 US states and US territories. So Puerto Rico, Guam, US Virgin Islands, all those would be okay, but not other countries. That's for non-controlled substances. Controlled substances, that it would have to be for a chronic condition, and then from those other states they'd be okay. Okay, I added a section on telehealth providers because this one's a little bit odd too. You know, both DEA tried to address internet pharmacies a while back, and they passed the Ryan-Haidt Act, which pretty much outlawed any prescribing over the internet of controlled substances, because you could go online and order controlled substances and have them shipped to your home, you know, back in the heyday of the internet pharmacies. I'm sure that's probably still available, maybe on the dark web somewhere. But for the most part, in the normal internet, that stuff's pretty well policed now and doesn't happen as often. But you do have telehealth, which uses the internet, right? So it's a little bit tricky, because even when the Ryan-Haidt Act was passed, people were concerned about telemedicine and telehealth. And DEA, when that law was passed, you know, it's been more than 10 years now. The DEA was supposed to come out with rules and a special registration for telehealth providers, because what that rule said was a prescription issued by means of the internet. In other words, the physician saw the patient by means of the internet, which could be a telehealth encounter, is not valid for controlled substances unless the physician has done at least one in-person examination. So in other words, you had to establish a doctor-patient relationship first in person. You could do follow-ups via the internet. That's not necessarily true today, because telehealth is an accepted practice, right? Particularly now when we're in this pandemic situation. That's pretty much the only way many people are getting their health care is through telehealth. And telehealth is actually addressed in Florida law. But Florida law specifically says that telehealth provider, it is recognized, but Florida says that telehealth providers cannot prescribe controlled substances, okay, unless it's for the treatment of psychiatric disorders, inpatient treatment of a hospital, so not outpatient, or the patient's in hospice or receiving hospice services, or for nursing home patients. So these four are the only times telehealth can be used to prescribe controlled substances in Florida, and that's in the middle of page 67. That's something you should probably make sure you take note of. All right, so designated agents. I included this because I wanted to make sure you understand that when we're talking about who can prescribe and so forth, a designated agent is not a person who can prescribe. A designated agent is a person who is designated by the DEA registrant, by the practitioner, to communicate the prescription or call in the prescription over the telephone. So they can communicate what the physician or the dentist or whoever the prescriber is, they can communicate what the prescription is and call it into the pharmacy on behalf of the prescriber. So they can communicate but not authorize or prescribe. So when you call to get a new prescription order or new refills on a prescription, and this is true for controlled substances or non-controlled substances, if you talk to the receptionist at the doctor's office and they answer the phone and you say, oh, Mrs. Jones needs a new prescription for this, and she's been on it for years, and the receptionist says, oh yeah, that's fine. That's not really how it's supposed to work, right? They're supposed to go check with the doctor and get permission, and the doctor's supposed to record it in the chart and then get back to you, right? So just remember, the designated agent can call in or communicate the prescription. They're not really technically the one prescribing. That became an issue a few years ago in nursing homes, because the nurses in the nursing home are not employed by the physicians who come to see patients there, and DEA took issue with that. They said, well, they're not really an agent. They don't work for the physician, so they can't call in the prescriptions to the pharmacy servicing that nursing home. And the way they worked that out was DEA said, okay, well, if the person who's calling in the prescription is not employed by the prescriber, that agency relationship should be a written document. That appoints them as an agent. So if you're in a long-term care or nursing home practice, um, I would advise you to make sure if nurses at the nursing home are calling in controlled substance prescriptions on behalf of physicians, make sure you have a copy of that agency agreement with that physician. Okay, so Florida has adopted some rules that are going to go into effect really July 1st, 2021, or they're actually kind of gradually going into effect as physicians and other prescribers renew their licenses. But it's going to require, this legislation passed in 2019, but it's going to require all healthcare practitioners who issue prescriptions, including controlled substances, so that's why we're doing it in this chapter, to issue them electronically. I think even after this law goes into effect fully in July 1st, 2021, because there are so many exceptions to it, you're still going to see written prescriptions. You'll probably see less of them. But that means on the MPJE, you're still going to see questions about the written prescriptions. And you got to remember, a lot of these questions have been written long time ago, right? Even before there were such things as electronic prescriptions. And because there are so many exceptions, they can probably keep a lot of those questions in the MPJ, and at least for till July 1st, 2021, it's not mandatory. So we're not going to go through all the many exceptions that are out there. Related to that is, so let's talk about the written controlled substance prescriptions starting on page 69. And again, in practice, a lot of people are already doing electronic, even before it's mandatory. But on the exam, I have a feeling you're probably going to see a lot of questions about written controlled substance prescriptions. So when you're talking about a written controlled substance prescription, it's got to be written on a counterproof pad in Florida. There's an official vendor. There's multiple vendors, I think, but you have to go to the Florida Department of Health, and the prescribers have to see who's an approved vendor to get these counterproof prescription pads. So before we went to the security of electronic prescriptions, this was a way to prevent fraudulent prescriptions with having these counterproof pads. That requirement is still out there if it's going to be a written prescription. Written prescriptions have to be manually signed. They can't be by the practitioner. They can't be signed by an agent, right? And they can't be signed with a ink stamp or rubber stamp or something like that. It's got to have the wet signature, we call it, of the prescriber. And if you look down on number 4, on page 69, these are the required elements that must be on a written controlled substance prescription. These are the kind of list you need to memorize. What's required to be on the prescription. Some of this comes from Florida law. Some of this comes from DEA law. So if you're coming from other states, you know most of this stuff. Make sure you pick up on the ones that are Florida specific. Like Florida requires that the quantity be written out as a word, not just a number, so nobody can add a 0 to that number to try and get more. Florida requires a prescription to be assigned a prescription number, and also a pharmacist must initial the prescription and the date it was filled on the hard copy of a written prescription. That's also a Florida specific requirement. And the next thing on page 70 is about changing information on a written Schedule 2 prescription. And I say Schedule 2 because it's really only an issue for Schedule 2. I talk a little bit about Schedule 3 through 5 in the middle of page 70, but if you think about it, if you need to change information on a Schedule 3 through 5 prescription, it's not a big issue, because for anything you're going to change, you have to call the prescriber, right? You can't just change something on your own, right? So let's get that out of the way first. Schedule 2, 3, 4, 5, whatever. If you're going to change something and something needs clarification, or it doesn't come in that dosage, we need to change that dosage, can you call the prescriber and get that information changed in a written prescription? And what DEA says is there's 4 things you can't change on a written controlled substance prescription, and those are listed on the top of page 70. I remember it this way: name, 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 and date. 3 names and a date. What are they? It's the name of the patient, who the prescription is written for. You can't call up the doctor and say, oh, did you mean to write it for this patient? Let me change the name. That's not allowed, okay? Name of the drug. You can't change the drug completely. Name of the prescribing physician who actually signed the prescription, and the date it was issued. Those 4 things can't be changed. So, like I said, though, if it's a Schedule 3 through 5, even those things, if you need to change one of them, let's say they wrote it for the wrong person, right? So I got four kids, right? So if they wrote the prescription for a controlled substance for a Schedule 3 through 5 drug, and they wrote it for the wrong kid, my doctor got confused, which, there's 4 of them. He can't remember which one's which. I didn't realize it. I take it to the pharmacy. It's a written prescription. And I said, oh, and they say, this is prescription. It's for Michael. And I said, no, it's not for Michael. I just took Vincent to the pharmacy. We need to change the name of who it's written for. Well, you can't do that. You can't. The pharmacist can't call and change the name, can they? No, they can't. But what else could they do? What can you do on a Schedule 3 through 5 prescription that you can't do on a Schedule 2 prescription? You can take a verbal prescription. So you can just tear up the one that I got written, right? And call the doctor and take a new prescription for the right patient and change it, so you're changing the name, but really you're not, you're just issuing a new prescription. So if somebody says you can't change the name, and date on any controlled substance prescription, that's technically true, but it's not a problem in practice for Schedule 3 through 5 drugs, is it? Because you can always just call and get a new verbal prescription if you need to change something. With Schedule 2s, it is a problem. Why is that? Because Schedule 2 prescriptions can't be phoned in, right? So you can't take a new verbal prescription unless it's an emergency, which we'll talk about later. So assuming it's not an emergency, if that same situation occurred and it was written for the wrong kid of mine, and it was a Schedule 2 drug, the pharmacist cannot simply tear it up and take a new verbal prescription for Schedule 2. What would I have to do? I'd have to go back to the physician and get a new written prescription. This stuff's all kind of crazy, right? Because we solve all of this with what? Electronic prescriptions, right? But on the MPJE, you got to know all these things, right? So name, and date are the 4 things you can't change. So you can change other things. If the prescription was written for the wrong strength, does the product doesn't come in that strength, even on the Schedule 2, you can change that. You have to call the prescriber and you have to document on the written prescription. Remember, we're talking about written prescriptions, that you got this changed and who you spoke to, and put, I would put the date and your initials there. All right. In fact, it requires you to put your initials there. So it's not that complicated. Some people get confused about it, but I think if you remember name, and date, Schedule 2 is where it's a problem. Okay. All right. Next, we're going to talk about verbal, fax, and electronic prescriptions. So we finished talking about written prescriptions. The first thing to remember is when we get, and we're going to talk about Schedule 2 and on the next page, not for Schedule 2, right? Verbal prescriptions are not allowed for Schedule 2, but for Schedule 3 through 5, you can take a verbal prescription, right? I want you to think of a fax prescription. Does anybody really fax anymore? I'm surprised how much people actually still fax in healthcare still, even in pharmacies still. But I want you to think of fax like a verbal prescription. And here's why: because it's not a fax is not an electronic prescription. Electronic prescriptions for controlled substances, sometimes abbreviated as EPCS prescriptions. There's very specific DEA rules on that, where both the pharmacy system and the prescriber systems have to be validated and secure, and the prescription's transmitted from one computer to another. That's an electronic prescription. A fax is not an electronic prescription. If you just think of it as a verbal, because the same rules, generally, the same rules apply to fax. So you can take a verbal prescription for a Schedule 3 through 5. You can take a fax prescription of a Schedule 3 through 5. The one issue that's a little bit different than Florida, which I've not seen this in most other states that I've looked at, Florida does not allow a verbal prescription for a Schedule 3 drug to be more than a 30-day supply. So a very specific Florida rule, which would not surprise me at all if they asked you that, because I've not seen that in other states. So remember that verbal prescriptions, Schedule 3, not more than a 30-day supply. If it's a written prescription of a Schedule 3, it could be more than a 30-day supply, and we'll talk about day supply in a moment. So for facts, they're fine for Schedule 3 through 5. When I start the Schedule 2 section next, we're going to talk about a few situations where a fax is valid for Schedule 2 prescriptions, where the fax can actually serve as the original. Because normally for Schedule 2, you got to have a written prescription or electronic. But there's a couple situations where we will take a fax and treat it like it's the original written prescription. We'll get to that next. We're going to cover Schedule 2 prescriptions in the next section. Okay, so Roman numeral 7, we're talking about Schedule 2 prescriptions. And like I said in the very beginning, we're talking about the schedules of controlled substances. You know, a lot of the questions are going to, the answer may depend on what schedule is this drug in? How do I treat it? And normally Schedule 2s are treated a little bit differently than other ones, right? So, first of all, it got to be written or electronic. There are no refills for Schedule 2 prescriptions. I'm going to say that one again. There are no refills of Schedule 2 prescriptions. I can't tell you how many times I get questions from students, and it'll be something about a refill and a Schedule 2, and I have to say there's no such thing, right? Okay, now we're going to talk about some things that look like refills, but they're not refills, because remember, there are no refills of Schedule 2 prescriptions, period. There's no such thing as a refill, okay? How long is the Schedule 2 prescription valid for? You're going to be surprised to find out that under federal law, there is no time limit for a Schedule 2 prescription. It's just one of those, it's a hole in the law that nobody's ever filled, right? Because when they wrote the Federal Controlled Substances Act, they said, okay, well, we're going to talk about Schedule 3 through 5 in a moment. Everybody knows Schedule 3 through 5s are only valid for 5 refills in 6 months, which means after 6 months, the whole prescription is not valid, either the original and the refills. So a Schedule 3 through 5 is only valid for 6 months. But federally, a Schedule 2, since it has no refills, that language is not anywhere in the federal law. So there's no expiration date for Schedule 2s under the federal law. Most states have put in, I should say expiration dates, a time limit before it's filled, okay? Most states have put that into their state laws. Florida has not done that specifically for Schedule 2, but Florida has a law that says any prescription, controlled or non-controlled, is only valid for up to 1 year after the date it was issued. So you have a weird situation here where Schedule 3 through 5s are only valid for 6 months, but technically a Schedule 2 prescription in Florida could be valid for 1 year. Now, would you fill it after 6 months or 7 months or 8 months, a Schedule 2? Depends on the situation. If you think it's a valid prescription and you exercise your corresponding responsibility, maybe. I mean, if it was something, for pain, I probably would not. So it's kind of weird but that's the way the law is set up. It's kind of a hole in the law. Here's the one that people don't believe me on a lot, but quantity limits. Is there a limit on the quantity that can be prescribed for a Schedule 2 prescription? The answer, surprisingly, is no. On a single prescription, there's no quantity limit or day supply limit, except Florida has a specific one for Schedule 2s for opioids for acute pain, which let's put that aside for a moment. We'll talk about that later. So am I saying that I could get a prescription not for an opioid for acute pain? I could get a Schedule 2 prescription. Let's pick one that's not an opioid. Let's do Ritalin because it's easy. And I need a 6-month supply. Can I fill that prescription? If you think it's a valid prescription, legally you could fill that. Or what if it's not for acute pain? What if it's for chronic pain? Somebody's got chronic pain, doesn't fall into the rule we're going to talk about later. Could you fill a single prescription for chronic pain for Vicodin? for, I don't know, a 9-month supply? Legally, you could, right? If it's a valid prescription. Would you do it in practice? Probably not. But I'm here to teach you what the law says, right? Um, Now you might be thinking, no, we can't fill more than a 30-day supply. Who said that? Oh, the insurance company won't pay for it. That's good for the insurance company. The MPJE is not testing you on what the insurance company said, though, right? Or my store policy says we can't fill it for more than a 10-day supply or something like that, right? That's your store policy. The MPJE is not testing you on what the store policy is. They're testing you on what the law says, okay? So even though you may never do it in practice, that's what the law says. Now, the weird thing is there might be a limit in certain situations, right? And we're gonna have to go, so I'll make sure you know all these other situations, right? So what I'm talking about here is a single prescription, not multiple prescriptions written the same day, right? That's coming up next. When that happens, there is a day supply limit, okay? And we talked about one other restriction as well, right? If that single prescription for a Schedule II drug is written by a PA or advanced practice registered nurse, what's the day supply limit? 7 days only, right? So they have a 7-day limit. But if it was written by a physician or a dentist or somebody like that, technically on a single prescription, there is no day supply limit. All right, why does that confuse people? I think it's because that nobody does it in practice, which is probably good practice. And insurance companies prohibit, have restrictions, and store policies sometimes are stricter. And then this is the next thing we're going to talk about, confuses people, right? And that is multiple prescriptions for Schedule II drugs written the same day. So this situation here is you got a physician who wants to give, let's say, a larger day supply limit of a Schedule II drug. And let's say they want to give a 90-day supply. What did I just tell you? What could they do? They could write a single prescription for a 90-day supply, right? There's nothing illegal about that. So why do we need this rule? Because what this rule says is a physician can write a prescription today and for a certain quantity, usually it's a month supply, so we'll go with a month supply. And today they can also issue another prescription for the same drug, same Schedule II drug, and it's for another month supply, and they can write on that prescription, do not fill until next month. You know, a specific date, a month in the future, or it's the earliest fill date it's called, or do not fill before date. But that prescription is issued today, and that's important. It's got to be dated today, because what a physician cannot do is post-date a prescription. They can't just write a prescription today and write next month's date on it. That's illegal. That's always been illegal. But what DEA is saying is, well, if you want to issue a 30-day supply prescription today, and you want to do another one for next month, and you can do one more for the following month, if you're issuing multiple prescriptions for a Schedule II drug on the same day, you can do that if you put the earliest fill date on the other prescriptions. Then when you do that, you're limited to a 90-day supply total. So you can go out 3 months. Now, if you think about what I just said, why do we even need this rule when I just told you they can just write a 90-day supply prescription? Well, it's for practical purposes. In the real world, we do have these things like insurance plans, prescription drug plans, and policies and things like that, right? And unless the patient's paying cash, their insurance company won't probably pay for a 90-day supply of a Schedule II drug. They may only pay for a 30-day supply. And this prevents the patient from having to go back to the doctor every month to get a written prescription. Because remember, you can't call in these prescriptions. Again, electronic prescriptions would solve this problem, right? But if we're talking about written prescriptions here. So that 90-day supply limit only applies when a physician is doing this multiple prescriptions for Schedule II issued the same day. That's the only time you have that 90-day supply limit. So you might use that as a guideline for a single prescription that, maybe I shouldn't go past 90 days on a single prescription. But I think every case is unique. If you've got a chronic pain patient who has cancer and they need a 6-month supply, legally you could probably do that. All right, so I mentioned facsimile prescriptions earlier, that normally a fax is treated as a verbal. And remember, we're still in this section, we're still talking about Schedule 2s. So this is letter B under Section 7, still talking about Schedule 2s. When can a fax be used as the original written prescription? Because you can't have a verbal prescription for Schedule 2. And normally we treat a fax as a verbal. Well, again, this one is more of a convenience thing, just like that multiple Schedule 2s 90-day limit is a convenience thing for patients. This is the same thing. This is when patients are not very mobile and can't go back to the doctor to get prescriptions. And again, this rule was written before we had electronic prescriptions. Electronic prescriptions solve that problem. But before we had electronic prescriptions, think about it. Especially if they had an insurance plan and it limited them to a 30-day supply, you could have a hospice patient or a nursing home patient or a patient who's on IV narcotic therapy at home. These patients are not very mobile. They'd have to get a physical, go to the doctor, get a written prescription, bring it to the pharmacy every month, right? So DEA said, okay, you know what? We're gonna, before we had electronic prescriptions, the best thing we had was fax. So they said, we're gonna let the fax for these types of patients count as the original. So in those rare circumstances, and you can read through them, if it's a patient who's on a Schedule 2 narcotic, remember not all narcotics are Schedule 2s. I mean, all Schedule 2s are not narcotics, right? So they couldn't do it if it was an amphetamine, but they could do it if it was, you know, morphine, right? And that's only for home infusion or people are getting IV therapy. And then for any Schedule 2 in a nursing home or long-term care patient, and then any Schedule 2 narcotic, either IV or oral tablets for a patient in hospice. So kind of a convenience thing for these particular patients. Okay. The next thing on page 73 is an emergency verbal Schedule 2 prescription. So this is an exception to the rule, right? The main rule is you can't do a verbal prescription for a Schedule 2. But this rule says in an emergency, you can. This is not an emergency refill of a prescription. I can't tell you how many times people get this mixed up, right? Why is it not an emergency? Florida does have an emergency refill rule that we'll cover for all prescriptions, right? And we'll talk about that a little bit later. But this is not that. Why is it not that? Because that's an emergency refill. What did I hammer home to you? There are no refills of Schedule 2s, right? So this is not an emergency refill. Don't get emergency refills mixed up with emergency verbal prescription for Schedule 2s. They're different things. Ironically, they have some of the same rules about time limits. Okay, so maybe that's good. If you get them mixed up, you might get the answer right anyway. So what this is saying in an emergency where the patient can't get to the doctor to get a written prescription for the Schedule 2, we're going to allow a verbal prescription to be called in. Again, electronic prescription solves this problem. But these rules were all written before there were electronic prescriptions, so you need to know them. And what it says is a prescriber can call in a Schedule 2 prescription to the pharmacy. The pharmacist must immediately reduce it to writing. And federal law says the amount that's prescribed is the amount limited to the emergency time period. So it leaves it a little bit open. And I always tell people, if you have a question on that, don't pick 72-hour supply or 7-day supply, or pick the amount necessary to treat the emergency time period. However, that's the wrong answer in Florida, because Florida specifically restricts it to a 72-hour supply. So an emergency verbal Schedule 2 in Florida is only limited to a 72-hour supply. Okay, and you're going to see the one I don't want you to get this mixed up with. The emergency refills are also 72-hour supply. Couple things here. The verbal order must come from the prescriber. It can't be a designated agent that you're talking to. Okay, and then that prescriber has to send you an original written prescription within 7 days, or they can do it electronically nowadays. And if you don't get one within 7 days, you're supposed to actually report that that practitioner to the DEA. So it gets to be day 5, you know, you might want to call the doctor and say, Doc, I took that emergency to take care of your patient, emergency schedule 2. You need to send me the original written prescription or I have to report you to the DEA. That usually will get their attention. Okay. All right, now next is the bottom of page 73. This is one that confuses people as well. And this is partial dispensing of a Schedule 2 prescription. This is not a refill, right? This is the one that looks like refills, but it's not a refill because why? There are no refills of Schedule 2s, but you can do something called a partial dispensing. And this one's got a little bit more complicated because a federal law was passed in 2016. It's been a while, but surprisingly, I guess not surprisingly, because DEA takes a while to do things, DEA has not implemented the rules that were passed in 2016. So what this says is the law always said that if a pharmacist gets a prescription for a Schedule 2 drug and they're unable to fulfill the full quantity on the prescription, because there are no refills, right? You can dispense a partial quantity, but the patient would have to come back within 72 hours to get the remaining quantity. Otherwise, they forfeit the rest of the prescription. So it could have been the patient request, or it could have been you just don't have enough, but you're unable to, whatever the reason, you're unable to fill it. They had 72 hours to come back. Now there's a little bit of a distinction, I think, because that language is still in the federal law. It says if you're unable to fill, they have to come back within 72 hours. But what the CARA amendments did in 2016, this is on page 74, said, well, if the patient requested the partial dispensing, they didn't want the full quantity, patient or prescriber, you can provide the partial quantity. They don't have to come back within 72 hours. They can come back within 30 days to get the remainder. And they can come back as many times as they want. They say, well, I may not need this full amount. They may want to get 2 tablets today and come back 3 days later, get 2 more tablets and get 2 more tablets. It looks like refills, I know, but remember, it's not a refill. It's a partial filling, right? The prescription was written for 30. If the patient says, I don't think I'm going to need all 30, I can't afford 30, you can dispense 2 tablets, 5 tablets, 10 tablets, whatever they request. But only if the patient requests it or the physician requests it can you continue to do this for 30 days. But remember, this is not a refill. And then for the long-term care patients and terminally ill patients, patients in hospice, you can actually do that for 60 days. And that's always been the rule. If you think about that, it makes a little bit of sense. The DEA actually would probably prefer that because they don't want a lot of excess controlled substances being stored at a nursing home. So it allows you to put into a bingo card or something, 5 week supply at one time of a Schedule 2 and do a partial fill of that, right? And you could do a 2-day supply or 3-day supply or 5-day supply, and you don't have to get a new prescription until every 60 days in a nursing home. But that's been kind of the same thing now for everybody, but for everybody else, it's a 30-day limitation. DEA hates that, I think, because to them it looks like refills, but it's not. It's partial filling of a Schedule 2 controlled substance. Okay. So I mentioned the Florida-specific rules about acute pain, and I really need to move this section, and I will in the next edition of the book, to the Schedule 2 section, because I think when I was putting it together, I forgot that it only applied to Schedule 2s. So it should go into the Schedule 2 section. Because some states have this and it applies to not just Schedule 2s, but in Florida, it applies to Schedule 2s, but not just all Schedule 2s. What this is, it's a limitation on the day's supply for Schedule 2 opioid drugs, right? So now the law is getting complicated. It used to be that if you knew it was Schedule 2, you knew all the rules, right? Now it depends what type of Schedule 2 it is, right? If it's a Schedule 2 opioid drug, there's a limitation on how much can be prescribed and how much can be dispensed. So we'll cover that a little bit later on the next slide. Okay. couple other things before we get there on page 74. There's a section you might, if you, when you know, if you actually go through and read the rules, which are difficult, and that's why we have this book, but there's some things that when you read it the first time just don't seem to make sense, right? And I had the same issue when I was going through these rules, right? So if you see something, this is in the statute in the Florida Pharmacy Act, there's a section there that says that, well, Schedule 2 and Schedule 3 controlled substance prescriptions can only be dispensed by community pharmacies. And like, what does that mean, right? Well, that was put in because prior to that law being changed, physicians could dispense Schedule 2 and Schedule 3 controlled substances, right? So a lot of the pill mills that we had, particularly in South Florida, were not pharmacies involved in a lot of them, some of them were, but initially some of these pill mills were physicians who, so-called physicians, I should say, would see patients, you know, and they would dispense their own controlled substance prescriptions. So not only did they take cash for seeing the patients, they would charge patients to pay cash to get the prescriptions right from the physician's office. So they eliminated most physician dispensing of Schedule 2 and 3 controlled substances with this law. So that's why it says only community pharmacies can do it. Hospitals can dispense to outpatients if they have a special type of community pharmacy permit as well. So that's what that means if you see that. The other thing was identification requirements, and this applies to all controlled substances, not to Schedule 2. But I put it here because we're still talking about Schedule 2, but it really applies to all controlled substance prescriptions. And it says that, you know, pharmacists must get an identification of the patient when they are dispensing controlled substances. But if you read it, it's kind of interesting. It says that if it's a person not known to the pharmacist, so I guess if you know the person, maybe it's a patient that's been a patient of your pharmacy for a long time, maybe you wouldn't have to get their ID. So it's kind of interesting the way that's worded, but it does require valid photo identification for controlled substance prescriptions. The other thing it says that, which is interesting, this is letters 3C on page 75, verification of health plan eligibility through an adjudication process is considered proper identification. So if they have insurance, and you adjudicate their claim through the insurance company, then you don't have to get their driver's license when you pick it up. I think a lot of pharmacies do it for all patients picking up controlled substances, but I find that an interesting loophole, I guess. So I put in a study tip so that, you know, the way I would interpret this, does Florida require identification? Yes, if the person's not known to you and maybe they're paying cash. But if they're agreeing to adjudicate it through insurance, then you may not have to. Kind of an interesting situation. It also says that if they don't have a proper photo identification, you can verify their identity by checking with the prescriber, which I'm not sure how you would do that. Do you just call up the prescriber to verify that this is the patient, or how do you verify it or maybe you take a photo of them and you text it over to the doctor? I don't know how that would work in real life. Okay. All right. And then number 4 on page 75 is you have to have policies and procedures for how you are going to prevent fraudulent prescriptions of controlled substances. So make sure you have that in your policies and procedures in your pharmacy. Okay. So I kind of jumped ahead there a little bit when I was talking about the acute pain stuff, because I got that later on, and it should really be in this section in Schedule 2. So we'll get to that in a moment. Let's talk about Schedule 3 through 5. We talked a little bit about them already, but so here's the thing. Not as many rules on these. They can be written, they can be verbal, they can be fax, they can be electronic, okay? They can be refilled, unlike Schedule 2s. They can be refilled 5 times within 6 months. Read the study tip on page 76 about partial fills. A lot of people get this mixed up and they interpret it wrong. And I think a lot of times, sometimes pharmacy computer systems interpret this wrong. If a patient has a Schedule 3 through 5 prescription and it's got 5 refills on it, they're entitled to 5 refills of the full quantity. If it's a 30-day supply with 5 refills, they're entitled to 30 plus 5 more refills of 30. But what if they only don't want 30? Maybe they want 10. Maybe they want 5. Can they do partial fills? Yeah, you can do partial fills of Schedule 3 through 5, just like you do partial fills of Schedule 2s. You're not limited to 72 hours or 30 days or 60 days because the prescription's valid for 6 months. So they can do partial fills for 6 months. But some people have told me they've been taught this, or their computer does it in their pharmacy, that when a patient gets a partial fill of a Schedule 3 through 5, every time they come back and get a partial quantity, the computer counts that as a refill. And after 5 times coming back, the computer says the rest of the prescription's not valid. That's wrong. The computer's doing it wrong. It needs to be reprogrammed. So I don't know if you've got that problem in your pharmacy, but legally on the MPJE, those are partial fills. If they got 10 and then 10 and then 10, that's the first 30. That's not 3 different refills. That's one. That's the original prescription. All right. So don't cut off the patients after 5 partial fills. Partial fills are not refills. Okay. All right. The next thing on Schedule 3 through 5 is transfers. Transfers of prescriptions are when you have a prescription at one pharmacy, and normally if it's got refills, it can be you want to transfer the prescription to another pharmacy to get the refills at another pharmacy. You've decided to switch pharmacies for some reason. The DEA rule for this, it says that if it's a controlled substance prescription as opposed to a non-controlled substance, a prescription can be transferred to another pharmacy only one time. So if it's at pharmacy A and you transfer the rest of the refills to pharmacy B, it can't be transferred again. You have to get all the rest of the refills at pharmacy B. The exception to that is if the pharmacies share a database, like within the Walgreens system, it can be transferred electronically back and forth within the same system as many times as there are refills. But if the pharmacies are not affiliated and not sharing a database, like controlled substance prescriptions can only be transferred one time. There's a big controversy and confusion about, can you transfer an original prescription for a controlled substance? An original, we're not transferring it for the refills, we're only transferring it for the original prescription. So this comes up in the context mainly of electronic prescriptions that were sent to the wrong pharmacy. Can we now transfer it to the correct pharmacy? And there's a lot of confusion about this. And here's what, I'm just going to tell you what DEA said and what the policy is. Not what's going on in practice, okay? If you read the rule that DEA has, it says that prescription information can be transferred to another pharmacy for controlled substance prescription for refill purposes. So if you read it literally, you could never transfer an original prescription that's never been, I say original means it came to the pharmacy but was never filled, right? And I think it comes up in the context of electronic, because if it came to a pharmacy and you didn't have it in stock, and the patient could come back and pick it up and take it to another pharmacy, that's not really a transfer because it was never filled. So it doesn't come up in the context of paper. It comes up in the context of electronic, right? So DEA said, you know what, we're going to make an exception by policy that we're not going to object if the prescription was electronic and like ECPS, electronic prescription for controlled substances, that was sent to the wrong pharmacy. If it was electronic, we'll allow it to be electronically transferred to another pharmacy even before it was filled. Now, I don't think a lot of pharmacies are doing this for 2 reasons. One, it's by DEA policy and they haven't changed the official rule yet, so some people get nervous about that. And number 2, I've been told that some computer systems can't do that. You can't transfer an original prescription. You can only transfer refills. So just know that's a policy. I would hope they wouldn't test you on a policy, but I will tell you it was NABP who kind of got that clarification and that policy from DEA. So all the boards of pharmacy know that's the policy. Okay, next thing on the bottom of page 76 and over to page 77 is the OTC sale of Schedule 5 products. I mentioned this in the first part of the controlled substance lecture, that there are certain products in Schedule 5 that are actually available. We say OTC, but it's not really over the counter. They had to be sold from behind the counter. These are what are called exempt narcotics. I don't think many people do this anymore, but it is in the Florida Controlled Substances Act, as it is the Federal Controlled Substances Act. So it is legally allowed, and you need to know the rules for it. These are products, as I mentioned before, that based on the concentration, fall into Schedule 5, such as Robitussin AC, Robitussin with codeine. Remember, it's got 200 milligrams per 100 mLs, keeps it right in Schedule 5. And there's also some like anti-diarrheal products that have a little bit of opium in them that are Schedule 5. These are products that can be sold without a prescription, kept behind the counter, but there's rules that you have to keep. They're really old-fashioned rules. You have to keep a bound record book. And I remember back in the day when I was in pharmacy school, they were real big about, it couldn't be a loose leaf folder. It had to be a bound record book. Um, uh, so a bound record book, and you have to record to get their ID and get the patient's name, and it's limited to a certain quantity every 48 hours. You need to know what those limitations are. In the federal rules, they do it by volume, but Florida, this is listed by milligrams, which I find interesting. So in the Florida law, it's 120 milligrams of codeine per 48 hours, 60 milligrams of dihydrocodeine, 30 milligrams of ethyl morphine, and 250 milligrams of opium every 48 hours. And I used to hear stories about patients used to know about this, and they'd come every 48 hours to get their Robitussin with codeine. Again, I don't think it's used in practice much anymore, but I have to cover it because it's in the competency statements for MPJE, and it's in the Florida law and the federal law as well. Okay, so make sure you read through that section. All right, now we get to the Florida restrictions on acute pain, which I apologize, I thought we were there earlier, but we weren't. And this is the section that I think I need to move over to Schedule 2 because it only applies to Schedule 2. So it's kind of in the wrong section. I've got it in the section for Schedule 3 through 5s under letter D, but I'm sorry, it's a new section. I made it its own section. So it's not in the wrong section, but I should probably move it over to after Schedule 2 or as part of Schedule 2 because it only applies to Schedule 2. So again, this is a response to the opioid crisis. And it limits the prescribing of opioids for acute pain to basically a 3-day supply. But it's only opioids in Schedule 2. So remember, there are opioids that are not in Schedule 2. Okay, there's less of them now than there used to be, but there are some that are in Schedule 3. As we just talked about, there's some in Schedule 5. So this is only Schedule 2 opioids, right? So it's a subclass of Schedule 2. The other thing tricky is it's only when they're being used to treat acute pain. So it's helpful to read through the definitions. The definitions are always important when you're reading the law. So you should know what is considered acute pain, and more importantly, in this case, what is considered not acute pain. Cancer is not acute pain, terminal conditions, palliative care. The bottom of page 78, a traumatic injury with an injury severity score of 9 or greater is not considered acute pain. That one's kind of interesting because to me, if you have a traumatic injury, that sounds like it's pretty acute to me, right? But I understand the reasons for that, right? They don't want to put limitations on if somebody's got a really traumatic injury. So they purposely define that as an exception from the definition of acute pain because we don't want to put limitations in that situation if that's serious, right? Chronic non-malignant pain, lots of things like that, right? So the main requirements are on page 79, letter C, any prescription for acute pain for an opioid in Schedule 2 can't exceed a 3-day supply limit, right? So remember my thing about there is no time limit for Schedule 2s. Well, there's a very strict one for Schedule 2 opioids for acute pain. It's 3 days, okay? Can't be more than a 3-day supply. Now, the physician or the prescriber can increase that to up to a 7-day supply simply by writing the words acute pain exception. If they feel like, yeah, my patient needs more than a 3-day supply, and I could see a dentist doing this. You have a procedure that takes a week to recover from, you're having your wisdom teeth pulled out or something like that, if they want to give more than a 3-day supply, all they have to do is write acute pain exception. But all that does is take it from 3-day supply to 7-day supply. Now, can they prescribe more than that? Only if it's for non-acute pain. If it's for, okay, if it doesn't, if it fits one of these things that's not defined as acute pain, a cancer patient, terminally ill patient, right? To get more than that 7-day supply, to get out of that completely, they have to write the words non-acute pain. So there's 2 different things they can write. They can write acute pain exception that takes them from a 3-day supply to a 7-day supply. But if they want to get out of the limitations completely, they got to let you know that it's a patient that has non-acute pain, one of these other ones that's defined as not acute. And then there is no limitation again. And the other thing that they said is that if that non-acute pain falls into that category of traumatic injury with a score of 9 or greater, if that's the reason it's non-acute, and this is the top of page 80, they have to also prescribe an opioid antagonist or naloxone. And they're supposed to prescribe that at the same time they prescribe the Schedule II narcotic. If they don't, fortunately, Florida's got a statewide, we'll cover this in a moment, a statewide standing order that allows a pharmacist to dispense naloxone under a standing order. So you should always dispense naloxone if it fits that particular situation. Okay, so again, that's a very specific Florida one that you should probably read. I included the frequently asked questions that I found on this one. There's a bunch of them that they have on their website, but I included the ones that apply to pharmacies to kind of help explain this, because the first couple of times you read it, it's a little bit hard to understand, and those are included for you on page 80. All right, let's move over to Roman numeral 10 and talk about methadone. So methadone first, and then a couple of other things. So methadone is a Schedule II controlled substance, and it can be used for pain. It's probably not the best, narcotic to use for pain. But the interesting thing about methadone is also used for what? It's also used to treat opioid addiction. But the trick here is that you have to realize that as a pharmacy, you cannot dispense any controlled substance, but it really comes up in the context of methadone, unless it's being prescribed for pain, for narcotics, because the dispensing of methadone to treat opioid addiction can only be done at an opioid treatment facility. And remember, an opioid treatment facility is a separate type of DEA registration. So if it's a prescription that shows up at your pharmacy, and your pharmacy is not part of an opioid treatment center, and it's for methadone, you can only fill that prescription if it's been written for pain. So a doctor writes a prescription for methadone. It'd be really helpful if it had for pain on it. Is it legally required? No. But remember, it's not a valid prescription unless they're treating pain. So, sometimes the doctor's trying to do the right thing. They have an opioid addicted patient, and they say, I'm going to start giving them methadone to try to wean them off of that Vicodin, right? The patient comes into your pharmacy, you're going to have to call the doc and say, look, I know you're trying to do the right thing here, doc, but I can't fill this prescription, right? And definitely don't fill the prescription on the MPJE exam. It's just not legal. Only narcotic treatment centers can administer and dispense methadone to treat narcotic addiction, okay? So when can you dispense a drug to treat narcotic addiction? You can dispense a prescription to treat narcotic addiction only under what's called office-based treatment on page 81. And that is from a data wave practitioner, right? Under the Drug Abuse Treatment Act, or a data wave practitioner, because there's not enough narcotic treatment centers. This allowed physicians, and now actually mid-level practitioners, such as PAs or nurse practitioners, can also do this. It's often called medication-assisted therapy, right? It's to treat opioid dependence. Specially trained physicians and now PAs and nurses, they're called data-waived practitioners. They get an X code in addition to their DEA code, can actually prescribe drugs to treat narcotic addiction, and you can fill those prescriptions in a pharmacy. Those are valid, right? A data waive prescription cannot prescribe methadone to treat narcotic addiction, and you couldn't fill a prescription even from a data waive practitioner. The only thing that they can prescribe are Subutex and Suboxone, right? Buprenorphine and buprenorphine naloxone combination products. So those prescriptions, if you get those from a data waive practitioner, you can fill those, but never methadone. Okay. All right, and I mentioned naloxone can be dispensed in Florida. Lots of states have this ability. Florida's really done a good job because they have a statewide standing order that covers all pharmacies. So if you feel like a patient is at risk of an opioid overdose, you don't have to call the physician to get a prescription. You can use the statewide standing order to dispense naloxone to the family member to use in an emergency in case of an opioid overdose. So that's a really good thing. All right. The next section on page 82 is the Methamphetamine Act. I think everybody's pretty much familiar with this. You know, it goes way back to 2005. This is a law that was passed to prevent illegal manufacturing of methamphetamine, you know, mainly from pseudoephedrine, you know, like on Breaking Bad, right? So when pseudoephedrine was over the counter, you know, people would that were running these meth labs would come out and wipe out all the pseudoephedrine off a shelf of a pharmacy or of a you know, a Target or something like that. So to kind of prevent that, we moved them behind the counter, right? So this was part of the Methamphetamine Control Combat Methamphetamine Act of 2005. So we moved them behind the counter, and we set retail sales limits. So you can read through the summary I have for you on page 82 and 83. Florida requires the record keeping for this to be, the federal law allows a log book where you keep track of, you know, when patients come in, which would be really hard to do unless you did this electronically to make sure they're not exceeding the limits. So everybody uses an electronic system, and Florida actually requires, on page 83, you'll see that you use the approved Florida Department of Law Enforcement's electronic record keeping system. Florida also requires that the purchaser be 18 years of age or older. Federal law does not, so that was a stricter thing that you should know. I think you need to know the retail sales limits on the bottom of page 82. They're usually listed as grams per day of the base product and grams per day per 30 days. So you can only get so much pseudoephedrine in one day, and also per 30 days. So it's 3.6 grams per day, and 9 grams per 30 days. The base product, I think the total quantity varies depending on the form of the pseudoephedrine, depending on the salt form. So I kind of did a calculation to show you what it was for pseudoephedrine hydrochloride, what the 3.6 grams turns into. I don't know if they would actually ask you to do that or not. More likely they would ask you what the daily limit is of the base product, 3.6 grams and 9 grams per 30 days. Okay. There's also training requirements. You can read through the rest of the summary on page 83 for that. All right, next thing is the Florida PDMP. So I think no matter what state you're going to go take an MPJE for, you need to learn about their PDMP, because every state has this, except Missouri. Last time I checked, Missouri didn't have one. Maybe, hopefully Missouri has one now. I don't know, I haven't checked recently, but they were the only state for a long time that didn't have one. So every state has different rules for this. This is a good source for questions for the MPJ, no matter what state you're in. So make sure you read through the requirements for checking the prescription drug monitoring program. These are programs that monitor who's prescribing controlled substances and who the patients are that are getting prescriptions filled, and which pharmacies are dispensing those controlled substances, to look for patients who are doctor shopping and that are also pharmacy shopping. They're going to multiple doctors to get controlled substance prescriptions, and they're going to, or going to multiple pharmacies. So it's trying to stop that sort of thing, right? Florida has made the use of the prescription drug monitoring program mandatory, which is a pretty good thing. A lot of states have wanted to do that, but a lot of times the physicians fight those kind of things. So Florida has mandatory checking of the PDMP. Anytime something's mandatory, what do you think you have to know? You have to know it's mandatory, but you have to know when it's not mandatory, right? The exceptions to the rule. Okay, so it's not required. You see this on the bottom of page 84 for patients under the age of 16, for patients who are in hospice. And then there's a couple other exceptions on the bottom of page 84. When a system's not working, we can't make it mandatory, right? Because of technological failure or electrical failure. They have these things called thunderstorms in Florida, right? Quite a few of them, particularly in Tampa where I grew up. So if the system goes out because of a bad thunderstorm, you don't have to check the system. Interestingly enough, if that happens on the top of page 85, you can only dispense a 3-day supply. Okay, so when I say it's mandatory, by the way, it's mandatory for the physicians to check it before they prescribe it, and also mandatory for the pharmacists to check it before they dispense it. Okay, so make sure you know the exceptions when it's not required. A lot of the reporting gets done automatically, right, through your computer system, but on the MPJE, you need to know the rules about how often these reports have to be filed with the PDMP, and what information has to be filed. And again, you don't worry about this in practice because it's done by the computer. But on MPJE, you need to know when does this reporting have to be done to PDMP. And on page 85, it tells you at C number 1 there, the close of the next business day, right? So anytime any controlled substance prescriptions that you dispense have to be reported to PDMP by the close of the next business day. And there's, just like the doctor doesn't have to check for certain patients, there's also exemptions for the pharmacies that we talked about. If you don't dispense any controlled substance prescriptions, you can request an exemption from reporting. But if you don't have the exemption and you don't dispense any controlled substances in one day, you do have to file a 0 report saying I didn't forget to report. I just didn't dispense any controlled substances. So there is a 0 reporting requirement, number 4 on page 85. And if you need to make a correction to the PDMP information, you sent the wrong information, that's got to be done within 1 business day of you discovering an error or something that you forgot to do. Then on page 86, it lists the information that's got to be transmitted to PDMP. Again, in practice, you probably don't worry about this, the computer's doing it, but you should know that list of what information. It's pretty detailed. It's not just the name of the drug and the prescriber. It's the prescriber's name, the prescriber's DEA number, even their NPI number, the date it was issued, the date it was filled, how it was paid for, cash or insurance, the NDC number, who picked it up if it wasn't the patient, which that's kind of interesting. So again, you want to make sure you at least be able to recognize that information if it comes up on a question. Remember, the PDMP information is sensitive information. It's confidential information. So it's only accessible if you have a legitimate reason to look up a patient's controlled substance, prescription history. It's got to be one of your patients. You can't just look up a neighbor or a friend for fun, or some celebrity. Every time a celebrity dies of a drug overdose, I hear about pharmacists getting in trouble for going to look up their PDMP record. You can't do that. Okay, it's a surefire way to get your license discipline, and it probably in any state. Okay. That's it for controlled substances. I know it's a lot of information, but we took our time going through it. I think it's worthwhile to kind of stretch it out a little bit and break it up into 2 videos because the controlled substance information is very, very important. From here on out, we're going to be talking specifically about the Florida laws going forward. So I look forward to seeing you again on our next video, starting with chapter 3.